Hi, everyone. We're just watching people trickle in, and we'll get started right away. Okay, let's get started. So hello, everyone, and welcome to our first Blue Dot live briefing. Today, we are going to be reviewing Blue Dot's latest assessment of the Omicron variant of concern. I'm Linda Chow, VP of Marketing at Blue Dot, and I'll be acting as your host today. A few housekeeping notes before we move into the briefing. At the bottom of your screen, you will see a Q&A button, and we will be leaving times for questions at the end. So if you press that button, you can add questions throughout the session as they come to you, and we'll answer them after our prepared assessment. Now, if you're having technical difficulties, you can reach out to us using the chat button that is also at the bottom of your screen, and we can help as much as we can. And then finally, after the session, there's going to be a short survey that will pop up after we close out the session, and there'll be a survey there. And we ask that you take a moment of your time to fill it out, as your feedback is very, very important to us. Okay, so without that out of the way, I'm going to introduce today's speakers. Dr. Andrea Thomas is a veterinary epidemiologist with experience in surveillance and quantitative epidemiology. She's also Blue Dot's epidemiology lead. It's her team that provides disease assessments for our clients. She and her team were responsible for developing the report on Omicron that you would have received on November 28th, as well as the Blue Dot Insight reports that you've received every day since then. At Blue Dot, Andrea has worked on projects involving the evaluation of West Nile virus surveillance in Ontario, enhanced surveillance for livestock disease, and the dispersion of COVID-19 in municipalities. Andrea will be the one who's presenting our threat briefing on Omicron a little bit later. Welcome, Andrea. And now I'm going to introduce Jen. Jen is an epidemiologist by training, and she was a Blue Dotter before the company was even founded. She worked with Blue Dot's founder, Dr. Cameron Kahn, on the Biodiaspora academic research program at St. Michael's Hospital in Toronto. And this is the academic research platform that became the basis of the Blue Dot Epidemic Intelligence Platform. So I'm going to invite Jen, who is our VP of Client Services, because I forgot to mention that earlier. I'm going to invite Jen to say a few words to you as the leader of that group.
Great. Thank you, Linda. I'd like to extend a warm welcome to all of our valued clients and partners for joining us today, and a warm welcome to all new colleagues joining us today. We know you are all very busy, and we appreciate your time. So Andrea, if you could advance to the next slide, please. Thank you. For those of you that don't know, Blue Dot was founded by Dr. Cameron Kahn, an infectious disease physician and scientist based in Toronto, Canada. Cameron was a frontline physician during the 2003 SARS-CoV event or pandemic that crippled our city here in Toronto. After watching colleagues and patients fall ill to this tiny virus that originated around the other side of the world, Cameron dedicated his career to combating the global spread of infectious diseases. Next slide. So Blue Dot is one of the world's leading infectious disease intelligence companies. Our mission is to create a more resilient world to the threat of infectious diseases. Blue Dot delivers value directly to our partners and clients through machine learning powered early warning threat detection, deeply contextualized threat assessments and reports, and intelligence delivered at a scale. While the platform is driven by AI, it is our multidisciplinary epidemic intelligence team that is at the heart of what we do. The team that reviews the insights, this is the team that reviews the insights derived from the platform and develops unique intelligence that empowers our clients and partners. This team is comprised of infectious disease doctors and specialists, data scientists, spatial analysis experts, veterinarians, epidemiologists, mathematical modelers, and others. We are proud to support a number of diverse clients across government sectors such as public health, animal health, defense, and security, along with other clients in the private sector such as airlines, airports, and organizations with global operations. Our data and products serve a number of different use cases. Do you want to just switch to the next slide, please? So here are just an example of some of the use cases so that our partners and clients have leveraged our data to empower. So initiating emergency response plans, informing public health policy, consumer and constituents confidence, knowledge transfer to clinicians, deployment of scarce resources, even supply chain management and demand planning. So without further ado, now that you know a little bit more about Blue Dot and our technology, I will hand it over to Andrea to walk through the Omicron assessment.
Thanks, Jen. So I'm just going to start here with a little bit of an analogy and sort of the way that we think about the work that we do at Blue Dot. So if we think about epidemics or outbreaks or pandemics as terms of wildfire, we can think about how do we try to prevent wildfires or control them. First, you need to be able to locate where the embers are and try to do that as quickly as you can. And that's something that we do every day, looking for outbreaks taking place around the world and trying to identify them as quickly as we can, using the combination of machine learning algorithms to sift through media sources around the world, as well as our human intelligence to try to understand what's happening on the ground. You also have to think about the direction of the wind. So this is sort of equivalent if we think about how diseases spread, and we know that they spread through movement of either people or animals or vectors like mosquitoes, and trying to understand that movement will help you get ahead of outbreaks more quickly if you can anticipate where they may go. If you can identify as well where that ember is going to land, you can get ahead and try to think about, okay, are those locations vulnerable? Are they suitable for fast transmission in that location? And you can try to get ahead of where those preventions might be best suited. And as well, if you can think about whether that ember is going to ignite, is it going to land in an area that's suitable for further transmission if you're thinking about outbreaks and where they might be taking place. So this is sort of equivalent to the work that we do every day at Blue Dot, trying to anticipate, trying to continue monitoring and looking out for where outbreaks may be taking place and where they may be spreading to next. The other aspect of sort of the way that we think about the work that we're doing is trying to deal with this problem that we have whereby we need expertise, we need enough epidemiologists and experts to understand and to track infectious diseases. But as probably many of us are aware, there are just simply not enough to do all of the work that's required, especially in a situation that we're faced with right now when we have a global pandemic taking place amidst all of the other infectious disease problems. So the work that we do really tries to take the load off of epidemiologists by leveraging machine learning algorithms and models, and trying to take that work so that we can then leverage the expertise that we have in combination with the machine learning algorithms to take that work off, and also to help our clients around the world who are also trying to combat the problems that they're facing. So as I mentioned, we are continually tracking infectious disease outbreaks using our machine learning platform. And then we have our team of surveillance analysts who are sifting through the information, contextualizing it, and that is what we're providing to our clients on a daily basis. So I'm going to go through the Omicron briefing at this time and just remind everyone who has seen our reports recently that we have been providing on an almost daily basis, trying to help make sure that everyone is able to stay apprised of the evolving situation, which is changing on a daily basis, it seems. So on the left is a report that some of you may have seen last week when we were first notified of the new variant, and we quickly identified that it was a concern. And on the right, we have a tool at the top that we have developed looking at air travel patterns, local mobility patterns, and integrating that with vaccination coverage, hospitalization data, and trying to identify locations that are at risk of early spread of the Omicron variant. On the bottom right is a sample of a daily email that we've been sending out where we're identifying countries every day that are having evidence of local transmission of Omicron or identifying it through travel. And this is part of one of the risk assessments that we provided earlier last week, looking at travel from South Africa, where we know is definitely one of the epicenters for the Omicron variant, looking at the locations that may have been most at risk of receiving cases prior to its identification. We can see that Zimbabwe is currently experiencing a surge in cases related to Omicron, and second on the list is the United States as the highest risk location. There are some countries in Europe as well that are high risk and definitely have noticed now that there is community transmission of Omicron. And then I think it's very notable that many of these countries that are high risk are, of course, in Africa, where we know that vaccine coverage is very low. Access to vaccines has been an ongoing concern, and definitely, these are locations where we are concerned about the impacts of Omicron. So there's some key questions that I think everyone is trying to answer as the evidence is emerging. And the three probably most important questions that I think are on the top of everyone's mind are: how transmissible is Omicron? What degree of immune erosion might we be seeing in terms of pre-existing immunity, either from natural infection or from vaccines? And how severe is the disease that it causes? So these are our current analytical judgments as of December 9th. And these are, based on the emerging evidence, and we have levels of confidence around them. But definitely as new evidence emerges, they are subject to change. At this point, we do believe that Omicron will spread quickly, and we have a high degree of confidence around that. This is based on a combination of variables, one being the mutations and their locations on the genome, but the other being what we're seeing occurring in locations that do have very good genomic surveillance, such as Denmark, where we're seeing rapid spread in that country. We're seeing that in the UK as well. And we're also noticing mass spread events, including among vaccinated people. We also expect more breakthrough and reinfections, and this is with a high degree of confidence. We assess that vaccines will very likely continue to protect against severe disease, and that's, I think, sort of being validated as we see that many vaccinated people who are infected are showing mild symptoms. But with increased transmission, we will have more challenges in controlling viral spread. We're watching countries like Israel closely, where they have already rolled out third doses of vaccine, and we're watching UK closely. They have probably a high level of combination of vaccine-derived and immunity from natural infection. And we're also watching for all of the laboratory studies that are coming out. Fortunately, the most recent lab data indicates that a third dose of vaccine will help protect against infection. And that was good news that came out yesterday. And now the final question, I think, is much harder to answer. And it's the one that, I think we're hearing a lot about in the media, which is how severe is Omicron. And initial reports, indicated potentially more mild disease, but I think we need to really think about how those can be interpreted, because what we're seeing are a lot of younger patients presenting at hospital for other conditions in South Africa. We have yet to really gather enough evidence from epidemiological studies to see how does this impact vulnerable people who are either unvaccinated or are in older age groups. So it's really too early to tell whether this will be of similar severity to Delta or more or less severe. And so we're just really kind of watching the data. Unfortunately, it does take 2 to 3 weeks from an infection until we can tell how severe that case will be. So because this is spreading so quickly, we don't really have a lot of time to wait for that data to come in, which I think is important to consider. So why do we think that it will spread more quickly? Again, this is based on the initial, the genomic analyses that came out were the kind of the first signal that this was a concern, because there were quite a number of mutations and their locations encoding the spike protein were a good signal that this would be a more transmissible variant. As well, the data from South Africa, Zimbabwe now, UK, and Denmark are highly suggestive of increased transmissibility. The observed reproduction number currently sits around 2 to 3, which is much higher than prior waves, including most recent waves of the Delta variant. It has already been detected in well over 50 countries now. There's likely much more undetected circulation as well. We're seeing a spike in cases in Zimbabwe, and we're also seeing this very high spike in a wastewater signal in Boston that has not been confirmed to be related to the Omicron variant, but it's higher than any spike that they've ever observed. And so we're watching for all of these types of signals. We're also seeing a growing proportion of cases that are unrelated to travel, which is indicating that there is community transmission occurring in quite a number of countries globally. How do we know, or why do we think that breakthrough and reinfections will be more common? Again, this is initially based on the mutations that encode the spike protein and other genes that were also similar to previous variants that demonstrated some immune erosion to those who were vaccinated or previously infected. There's a growing collection of reports of breakthrough infections in fully vaccinated people, including some mass spread events among fully vaccinated people in Norway, Spain, and the US. We're seeing the epidemiological data from South Africa and more recently Denmark, which suggests greater reinfection risk than they had experienced during prior waves. And the preliminary results of neutralizing antibody studies are now indicating again a drop in potential immune protection against infection. Cellular immunity studies are forthcoming, and we do expect this, the vaccine should still fortunately protect against severe disease. And the other good news that I had mentioned was that a third dose does appear to be protective against infection. So I think, the consideration of now this, the vaccine series of a 2-dose vaccine is really should be considered a 3-dose vaccine for full coverage at this point. The question on severity. So earlier reports, as I had mentioned, were that there were milder illnesses presenting in South Africa. But we need to think about the fact that South Africa has experienced several very large waves of previous variants. So they do have a level of natural protection. They also have a certain level of vaccination protection. I think they're at around 35% coverage of their population. So until we really have enough time to understand the impacts on vulnerable populations, older age groups, people with comorbidities, and the unvaccinated, it's actually quite hard to tell whether this is a more severe or less severe variant. We do assume and judge that vaccines and prior infection will continue to reduce the chance of severe disease. And we believe that if Omicron were significantly more virulent than Delta, we probably would have observed at least some more severe cases than have been reported to date. And as I had mentioned, the data on hospitalizations, they will be highly informative. We just haven't had enough time for those to come in to really inform our evaluation. And the spike in cases in South Africa is so rapid that we still need to wait for those cases to develop and to understand how severe some of them may be. So it's quite early on still, unfortunately. So what is our anticipation of sort of the evolution of the situation now with Omicron? So we do, definitely believe there's increasing Omicron transmission worldwide. It's anticipated it will probably overtake the Delta variant as the predominant variant now, as we're watching the increasing transmission in places like the UK and Denmark, where they have quite high transmission already of the Delta variant circulating. And so we can think about probably, the two different groups of populations. We have our immune populations, where we expect to see a greater number of breakthrough infections. Hopefully, we will still continue to see predominantly mild illnesses among those groups. And then we have more susceptible populations with either, naive immune systems or low immunity. And through these populations, we expect to see accelerated transmission and likely a rising number of hospitalizations for severe illness, just based on the sheer numbers of infections that we are observing and anticipating. And then as well, with our immune erosion of previously vaccinated or infected individuals, we will also have spillover into susceptible populations. This is a little image of a risk assessment tool that we've developed just over the last week. And we chose initially to focus on the United States, being the second most likely location to have received travelers from South Africa. So this tool is looking at air travel data. It's also using a model to estimate the movement of people from airports by land and where they're most likely to reach their final destination, where those destinations are. So here we have our two top locations or top three locations being New York City, Miami, and Los Angeles. We have a layer for the county level vaccination coverage. So assuming based on the coverage of vaccinations that areas with a lower vaccination coverage are at higher risk. And we've identified some other areas based on that risk assessment that have a surrounding region with low vaccination coverage. And then if we also layer in hospitalization rates, we can look at areas that are already experiencing a high burden of illness related to the Delta variant, which is surging again in the United States currently, and where we can understand that there's even greater vulnerability as Omicron spreads in those populations. And I will just close in saying that we're continuing to monitor the situation. We're developing the tools to look at this from a more global aspect as well. I think, it's important to understand it's still too early to know the severity of the illness, but we know that we need more measures in locations that are already struggling to contain the Delta variant and experiencing high transmission, because there's really not enough time to wait and understand how severe this variant may be. It seems to be spreading very quickly, and I'll leave it at that, and I'll open up for any questions.
Thank you, Andrea. That was a really great assessment, and we appreciate you sharing your expertise with us. So as Andrea said, we're going to open it up for questions right now. And if you recall, there is a button on the bottom of your screen that says Q&A, and you can use that to submit your questions to us. So Andrea, we'll start with this first question from the audience, and that is, what factors should you consider when you are thinking about transmissibility once Omicron has arrived?
I guess in terms of like what we think the impacts might be, I'm assuming that question is related to. So, well, the some factors I've already kind of described, which would be what is the underlying vaccination coverage. We know that, you know, natural infections can provide some immunity as well. We're looking at, you know, some locations now are rolling out third doses, and that will be very protective. So we, you know, locations that have begun their rollouts and are doing that quickly and getting third doses into their populations will be at less risk. There's many factors. It's the same types of factors that you would think about for the Delta variant as well. So I would kind of say that anywhere that is struggling to contain the Delta variant is at risk for further, you know, further challenges to their healthcare systems if they're not able to decrease transmission currently. That's definitely a concern.
Thanks, Andrea. Oh, sorry. Go ahead.
Oh, I was going to read that question. Do we expect new Omicron to outpace the Delta variant? I think if I had been asked that even a few days ago, I would have less certainty around that answer. But the pace that we're seeing it growing in countries that have already high rates of Delta variant that are tracking genomic surveillance data very closely indicate that yes, it probably will outpace the Delta variant. I think the estimates from the UK right now are that it may be the predominant variant within even as short as a month from now. What are the
okay, Andrew? Yeah, so we've got a couple of questions about the differences between Omicron and Delta, or the native COVID-19, and so maybe you could describe what the main difference is for us.
Yeah, I mean, the main difference is, I think what really raised the red flag initially was just that this variant it was so different. It made such an evolutionary kind of jump from all of the previous variants that there's several theories about how that may have occurred, but regardless, it's different enough that our immune system has not it's not as adept at recognizing it and preventing infection. So that's probably the main concern, is that, you know, individuals who have either been previously infected with a previous variant or have had 2 doses of a vaccine series of a 2-dose vaccine, it is different enough from the wild type and then from the other variants that we've experienced that we're not as able to prevent it from infecting cells. And fortunately, the 3rd dose does appear to bring that immunity level back up to where it would have been when we looked at 2 doses against the wild type strain, which is what the vaccines were developed for.
Great, thanks, Andrea. The next question comes from the Taiwan CDC, and they are asking, what was the source of information for the confirmed cases of Omicron in China in December? Did you show, so on your chart, was China on that list?
Probably. I would have to ask the surveillance team. So we have our team of surveillance analysts who are sifting through official reports and media reports on a daily basis to identify where it is being observed. And they have a list of criteria as well. So to signal that something might be community transmission versus within a traveler. And so, for example, one criteria, this is not related to China, but one criteria might be if we see a traveler arriving in a different country from another country infected with Omicron, then that's a signal that Omicron is probably spreading in the origin country. And so we have a list of these sort of criteria that we're using to determine probable community transmission or definite community transmission when it's officially reported. As far as China, I can't answer that specifically, but we can get back to you.
Okay, thank you.
I'm happy to take that one back, Andrea, and I'll communicate with Pei-Chen.
The next question says, with this level of mutation that we've seen on Omicron, what are we anticipating for future variants?
This is an area of work that, I think we're all still learning about unless we're really an expert in that field. But I have seen sort of those studies that suggest that contrary to what we might hear, whereby we think that over time mutations may become less virulent and we may be, in a scenario where we have a milder illness, the experts that I've been reading are suggesting the opposite. So I think what this is just showing is that this is keeping us on our toes. I think, trying to control transmission globally obviously is a better solution than hoping that this will continue to evolve into a less bothersome virus. It's been showing us the opposite, as we've been experiencing the pandemic. So I can't answer that from an expert point of view, but it's something that we are trying to understand.
Okay, so it looks, let me just see if there are any more here. No, it doesn't look like that there are any more questions. There had been some about the third vaccine, but I think you've covered that. So I am going to say thank you to everyone for attending today. And if there are any additional questions that you would like answered, please reach out to your client services person, or you can contact us in one of the ways that are at the bottom of your screen. If you contact hello@blue.global, you will be able to have a direct response from us. And so if there are any further questions that come our way, please do not hesitate to reach out. So as we close out today, we'd like to thank you very much for attending and remind you that there will be a survey that pops up as we close out. And we'd love for you to take a moment of your time to fill it out so that we can have your feedback. And with that, we'll say goodbye and take care.
Thank you.
Have a great night, everyone.